So let's start by looking at the black box warning that is present on the FDA label of every antidepressant. So it states, warning, suicidal thoughts and behaviors, and the 2 bullet points are increased risk of suicidal thinking and behavior in children and adolescents and young adults taking antidepressants. And the second bullet point is monitor for worsening and emergence of suicidal thoughts and behaviors. That's a pretty scary label for someone with depression. So do antidepressants increase suicidality? Most papers suggest that the risk of suicidality is strongly age dependent. And the general pattern is an increased risk of suicidality and suicidal behavior in patients under 25, and then a neutral and possibly protective effect for patients 25 to 64, and then a reduced risk of both suicidality and suicidal behavior in patients 65 or older. So the paper that we're going to take a look at is the paper that led to the black box warning that we see on the FDA label. So just a small pause in the video. If you enjoyed this content or my other content, definitely head over to psycho.farm and check out the new antidepressant course. So I put together a course with a ton of videos that go over depression, SSRIs, SNRIs, TCAs, MAOIs, and the atypicals. I made it with the intent to be accessible and practical. I think it's worthwhile if you're a student or a practicing psychiatrist, you'll still get something out of it. But let's get back to the video. And that paper is titled Suicidality in Pediatric Patients Treated with Antidepressant Drugs. So the introduction of the paper discusses the sequence of events that led to the FDA investigating this. So the first evidence that antidepressants may be associated with increased suicidality was in June 2003 in a report to the FDA from GlaxoSmithKline, who was the manufacturer of paroxetine. And this report suggested an increase of suicide-related events, particularly in patients with depression. This report led the FDA to request the manufacturers from 8 other antidepressants to look in their databases for pediatric studies looking for suicide-related events. This preliminary search showed an apparent increase in suicidality risk, and based on the summary data from these searches, the FDA significantly expanded its investigation. Basically what they did was they got even more data from the pharmaceutical companies, notably adding the suicide item scores from the depression rating scales, and also getting help from suicide experts to help understand the data. And then the paper that we're discussing now, Suicidality in Pediatric Patients Treated with Antidepressant Drugs, discussed the results from this investigation. So now I'll just simplify some of the results that they found. So they had data from over 4,000 patients in 24 pediatric trials of 9 different antidepressant drugs. And what were the big findings? First, there was no completed suicides in any of the trials evaluated. Next, the relative risk of spontaneously reported suicidality for SSRIs compared to placebo was 1.66, and for all antidepressants, it was 1.95. Now, when they say suicidality, they're referring to suicidal behavior or ideation. Those fell into 3 separate categories, which were suicide attempts, preparatory actions towards imminent suicidal behavior, and suicidal ideation. So the increase in suicidality is referring to those categories and not completed suicides. So here the relative risk was 2, and that sounds scary, but when you're looking at the absolute risk, the number for risk difference is 0.01. Putting that into terms that a human can understand, if you treat 100 kids with an antidepressant for depression, about 1 to 3 will report suicidal ideation or behavior that would not have otherwise occurred with placebo. And then the last result that I'll mention is that when they looked at the suicide-related items on the depression rating scales, there was a non-significant decrease in the risk of worsening suicidal ideation or emergence of suicidal ideation. Saying that another way, on depression rating scales, kids reported less suicidal ideation if they were on an antidepressant, but it didn't separate out from placebo. All right, so to quickly recap those results, there were no completed suicides, the relative risk for suicidal behavior and for suicidal ideation was about 2, the absolute risk was super tiny, and on self-reported scales, there was largely no difference in suicidality. Now let's just move to the discussion from the paper. So note that there's been a long-standing concern that antidepressants worsen suicidality early in treatment. And a super old textbook from over 50 years ago even points out this observation. With beginning convalescence, the risk of suicide once more becomes serious as retardation fades. I'll talk more about that in a second. So this concern of the increased suicidality intensified in 1990 with the publication of an article describing 6 adult inpatients who became more suicidal as a result of being treated with fluoxetine. This led to the manufacturer doing a pooled analysis of their controlled trials, and they didn't see an increased suicidality with fluoxetine. As time went on, they had more and more data, and they were able to do more meta-analyses, but they continued to not find a significant difference in attempted or completed suicide. I mentioned in the introduction that these concerns re-emerged in 2003 when the manufacturers of paroxetine saw an increase in suicide-related events in kids treated with paroxetine with depression. So what were the conclusions from the paper we're discussing now? So their big concern was the observed increase in risk of suicidality, showing a relative risk of 2 or greater. They noted that even though there was no completed suicide in these trials, they aren't able to make any conclusions on this because it's possible that the sample was just not large enough to detect an effect. They also note that it's pretty troubling that they saw an increase in suicidality, but didn't see an increase in the suicide items in the depression rating scales. There's possible explanations for this lack of concordance, but still it's pretty weird that kids weren't reporting suicidality when they saw an increase in suicidality. So the FDA presented the results of this analysis to a joint meeting with a bunch of different committees, and the committee agreed that the data suggested a risk of antidepressant-induced suicidality in kids, and that this risk was best understood as applying to all antidepressant agents. And this is what led to the black box warning that felt it was necessary to alert patients and their families and the caregivers of this risk. The paper concludes that it's important to be clear that the FDA has not contraindicated these medications in kids, and recognize that depression has significant consequences if it's not appropriately treated. Now, just to summarize the findings from this paper, antidepressants were not associated with completed suicide. They were associated with an increased risk of suicidal ideation and behavior when the symptoms were reported spontaneously, but not when the symptoms were assessed systematically using rating scales. So that caps up the paper. I'll just point out that this paper had a really big impact on prescribing patterns, and several studies found a decline in the prescription of SSRIs to kids after the black box warning was issued in 2007. But it's worth noting that the American Academy of Child and Adolescent Psychiatry feels that the overall risk-benefit ratio for SSRIs is favorable as long as careful monitoring is in place. So the purpose of the black box warning was really to increase monitoring that occurs during the initial phase of prescribing an antidepressant, but unfortunately had consequences that decreased the prescribing of the medications and an understandable increase in parents' hesitations to put their children on SSRIs because of a surrounding lore that the medication may increase a patient's suicide risk. So now I'll just take a second to discuss some of the possible reasons that we see this increased risk. The reason that I've heard cited the most is that when we treat a patient with antidepressant, their neurovegetative symptoms improve before their mood symptoms. To put that another way, there are different sets of symptoms in depression. There are mood symptoms like sadness, guilt, and suicidality. And then there are physiological or psychomotor symptoms like motivation and energy. So it's possible that antidepressants improve the psychomotor symptoms, which improve energy and motivation, but that the improvement in mood symptoms lags behind this. So the patient starts to physically feel better and get more motivated, but they still have low mood and negative thoughts, which could lead to an increase in suicidal ideation and behavior in patients susceptible to those symptoms. Now, of course, this isn't the only possibility that could potentially increase the risk of suicidality. It's also possible that some patients are going to have undiagnosed bipolar, and the SSRI could push them into a mixed or manic state. I can also imagine more psychological explanations. For example, a patient comes in very suicidal, and they're holding out hope that they'll feel much better from taking a medication, and then they don't. I would imagine that would push them into feeling even more hopeless. And one last point that I think can be important, we often see suicide severity treated as if it's a progression of symptoms. For example, the Columbia Suicide Severity Rating has a progression of symptoms from passive suicide thoughts to active suicide thoughts to method, plan, and then intent. But in reality, suicidal ideation versus suicide attempts versus completed suicides are actually 3 different things that only partially correlate. And that for different patient populations, suicidal ideation may actually represent different things. In that for some patients, suicidal ideation is more a representation of intolerable emotional feelings than it is for a desire to not be alive. Now, that's not necessarily true for all patients, but I just bring that up to make the point that it's not a clear escalation in severity of going from suicidal ideation to completed suicides. Thanks for watching. There's a link in the description for a 1-page summary of this paper. And again, a shameless plug, go to psycho.farm to check out the new antidepressant course. Thanks for watching.